is increasingly getting used, and I'll talk a little bit about that more in a second. Increasing skilled birth attendance is considered by most countries and WHO and whatnot to be a significant contributor. If you can increase skilled birth attendance, you'll reduce maternal mortality. I think there is one estimate from the study showing that I think for every 10% of increase in women you can get with skilled birth attendance, you have a corresponding, I think, 5% reduction in maternal mortality. So that's a big one. Medical abortion, access to safe abortion through medical abortion, misoprostol or MBA can address this 13% contribution of unsafe abortion to maternal mortality. And I'll talk a little bit more about PSI's work in that, although this whole series, there have been a couple of separate brown bags specifically on abortion, so I'll touch on that only briefly. And then the last one is a newer area, preeclampsia and eclampsia, and use of magnesium sulfate in prevention to address that. And I think eclampsia and preeclampsia in the public health world for maternal mortality is sort of the forgotten major contributor to maternal mortality. It's up to, contributing up to 19% of maternal mortality in some countries, so it's right up there with unsafe abortion and close to postpartum hemorrhage as a cause of maternal death.
Dana, when you say skilled birth attendance reduces mortality, is that in a facility or regardless whether they're in a facility?
I think most of the literature is facility-based delivery, but there have been a lot of increase in trainings of midwives, for example, in many countries, and I think midwives are both doing deliveries in facilities and at home, but I think the evidence shows that at the community level, you have to have access to transport and medication for most of these complications. So if you're delivering at home with a midwife, it may help, but if there's a complication such as postpartum hemorrhage or eclampsia and you don't have the medication in the facility, or they need obstructed labor and they need a delivery, you still have to have access to emergency care. So increase in skilled birth attendance, I think it's one step to have midwives at a home level where we can administer some of these things that PSI is getting involved with, such as misoprostol, but that have potential to have an impact at the community level. But I think historically, training of TBAs, for example, was done for years and years and years through big global maternal health initiatives and shown to have no impact in maternal, or very little impact in maternal mortality. I don't know, Krishna, if you have anything to add to that. So the emphasis has been to date on increasing facility-based delivery, where there's access to medicines and C-sections and emergency obstetric care. But I think with some of the newer technologies, such as misoprostol, that there may be potential to impact maternal mortality at the community level in the home with administration of simple drugs to save women's lives and address major causes of maternal mortality like PPH. So that's something that PSI is involved with, and hoping that we can contribute to the evidence for that through some of the work that we're doing.
Excuse me, in your previous slide, what do MBA mean?
MA is medical abortion, and I'll talk a little bit more about that. MBA is manual vacuum aspiration. It's a surgical procedure for terminating pregnancy. Also is used for post-abortion care where the uterus needs to be evacuated from an unviable pregnancy or a partial abortion. And medical abortion is a combination of drugs that can be used to terminate a pregnancy, mostly in the first trimester, although there's some research going on for use of that in the second trimester as well. So I'll talk a little bit about that in a second.
So misoprostol is a separate
misoprostol is, well, okay, I'll talk about it in a minute, but medical abortion is a combination of two medicines. One is misoprostol and the second is mifepristone. And in combination, these drugs have almost 100% effectiveness in terminating a pregnancy safely. Misoprostol can also be used alone to terminate a pregnancy, but the effectiveness is slightly less than when you combine it with this other drug. And I'll talk a little bit more about that. And the manual vacuum aspiration has to be done in a clinic by a doctor, and is an evacuation procedure of the uterus using a syringe or suction. So what's PSI doing to address maternal mortality, and what more can we do? So let me talk about, I think I'm going to talk about 3 or 4 interventions that PSI is doing, and a couple of possibilities for what more we could be doing in other areas. Let me talk about postpartum hemorrhage first. Why is PPH? What's the problem around postpartum hemorrhage? Why is it contributing such a huge proportion of maternal deaths globally? The majority of births are developed most women are living in rural areas. Demographically, women are living in rural areas, and most of them are poor, and they're delivering at home. And at home, most of these women are not having skilled birth attendants. That means somebody formally trained in identifying emergencies and helping refer. It may be a traditional birth attendant or aunt, not uncle normally, or other family friends. Normally uncles don't come and deliver a baby. Even where women have access to perhaps a lower level health facility, even if they're brought to a facility, as we were talking about in the 3 delays, for postpartum hemorrhage you need to administer drugs to prevent it or to treat it. And oxytocin, as I was saying earlier, requires a cold chain